Bismillahirrahmanirrahim. My name is Dr. Arif Zaheer and I am Professor of Pediatrics at PGMI Amiruddin Medical College, Lahore General Hospital, Lahore. Today I am going to discuss a very common condition known as pneumonia, and I will particularly emphasize on the diagnostic approach to a child presenting with pneumonia. The learning objectives are that by the end of this lecture you will know the definition of pneumonia, classifications of pneumonia, etiology of pneumonia, signs and symptoms of pneumonia, laboratory diagnosis, the management plan, complications, and prevention of pneumonia. Pneumonia is defined as inflammation, oblique infection of the lung parenchyma associated with consolidation of the respiratory unit, particularly the respiratory bronchioles, alveolar ducts, alveolar sacs, and alveoli. As you all know that the gaseous exchange takes place at the level of alveoli. So in case of pneumonia, when there is infection and inflammation of the alveoli, there is exudation of fluid that collects in the alveoli, leading to consolidation of that part of lungs. So hence there won't be any gaseous exchange at that level, leading to mismatched perfusion ventilation ratio. There are certain facts about pneumonia. Pneumonia is still one of the leading causes of death in the developing countries around the world. Around 92,000 children die of pneumonia annually in the country, and the authorities must focus on eradicating the deadly disease on a priority basis. As compared to all other diseases, pneumonia causes the largest number of children deaths in the country every year, despite the fact that it is preventable in 90% of the cases through vaccination. Now, if you look at this picture, you can see that in infancy, the most of the patient, they die because of pneumonia, and pneumonia accounts for about 19% of deaths in the infants. And this is closely followed by the premature babies. Prematurity is another important cause of death in the infants, and this is followed by diarrhea, which is particularly common during the summer season, and it accounts for a large number of deaths in the infancy. Now, if you look at the deaths among children under 5 years of age, you can see that pneumonia still accounts for a majority of the deaths that occur in the children who are under 5 years of age. And then of course the other causes are neonatal deaths, particularly due to asphyxia, prematurity, or sepsis. And then there are a large number of deaths that result from diarrhea, leading to severe dehydration and multiple problems, and these deaths are mainly during the summer season. Then as far as the etiological agents of pneumonia are concerned, they vary with the age of the patient. In the early onset sepsis, that is within the first few days of life, the most important organism is group B streptococcus, and during the neonatal period, the organisms which cause pneumonia or sepsis, they include E. coli, Klebsiella, Listeria monocytogenes, and then Staphylococcus aureus, which causes very fulminant infection in the neonatal period, and then few anaerobes. During the initial few months, the E. coli dominates the picture, and it is the important organism which causes most of the infections, followed by sepsis, followed by Staphylococcus aureus and Haemophilus influenzae. But as the age advances, Haemophilus influenzae, Streptococcus pneumoniae become the predominant organisms causing pneumonias. And then after 5 years of age, the Streptococcus pneumoniae is the important organism that causes pneumonia. Haemophilus infections are common before the age of 5 years, and subsequently Streptococcus pneumonia is the commonest organism that causes pneumonia in the pediatric population. The atypical organisms like Mycoplasma pneumoniae, Chlamydia, they cause pneumonia in relatively older children, particularly the school-going children. There are different types of classification of pneumonia, and one of them is the community-acquired pneumonia and the hospital-acquired pneumonia. Community-acquired pneumonia is these are the cases which acquire infection while they are at home. They acquire infection from the community, and their organisms are different from those who acquire pneumonia in the hospital. These children are admitted in the hospital due to some other reason, and they acquire infection or pneumonia in the hospital, and the organisms are different, particularly the Pseudomonas and Staphylococcus aureus are the organisms which are responsible for the hospital-acquired infection, and majority of these organisms are resistant to the treatment and they are difficult to manage. Pneumonia may be lobar pneumonia or bronchopneumonia. So this is another way of classifying pneumonia. In bronchopneumonia, there are areas of small patchy consolidation, while in case of lobar pneumonia, a large segment or a large part of the lobe is involved. It undergoes consolidation and it is known as lobar pneumonia. Then there is another way of classifying pneumonia depending upon the causative organism. For example, there may be bacterial pneumonia, there may be viral pneumonia, there may be fungal pneumonia. Now, whenever a child comes to you with cough, we have to ask certain important is the child able to drink or breastfeed? Does the child vomit everything, or has the child had convulsions? And then we have to look certain thing, particularly the conscious level of the child, the activity of the child. If the child is having cough, we will ask for how long the child is coughing, and then we will look, listen, and feel certain things. The most important thing we must look at is the respiratory rate of the child. So that is the most important thing, followed by chest rendering and certain danger signs. So you have to look, you have to emphasize, you have to concentrate or focus on respiratory rate of the child, chest in drying, and certain danger signs in order to classify the pneumonia. So this means that you can easily classify the pneumonia, or you can easily assess the severity of the pneumonia even without using a stethoscope. So for that matter, you must know the upper limit of respiratory rate at certain ages. If the age of the child is less than 2 months, the upper limit of respiratory rate is 60 per minute. And if the child is between 2 months to 12 months, the upper limit of respiratory rate is equal to or more than 50 per minute. And if the child is between 1 year and 5 years of age, we label fast breathing when the rate of respiration is 40 per minute. So remember the figures of 60, 50 and 40. 60 up to the age of 2 months, 50 up to the age of 1 year, and after 1 year the upper limit of respiratory rate is 40 per minute. So if a child is having fast breathing, that will indicate that the child is having some problem in the chest, and in most of the cases it is the respiratory system which is involved, and the child is likely to have pneumonia or pneumonia with complication. Very few of the children, they may have some cardiac problem like myocarditis. Then we look for indrawing of the chest. That indicates that the child is having increased work of breathing and is having difficulty in breathing. Obviously that will also indicate that the child is having some problem in the chest, maybe lungs or heart, and in most of the cases it is because of pneumonia or related disorders like bronchiolitis, asthma, or hyperactive airway disease. Then listen to certain danger signs like stridor. Stridor is a sound which is produced when the child inspires, and it indicates upper airway obstruction. These are the musical sounds which are heard towards the end of expiration, and they indicate narrowing of the small airways. Then of course we will look at the cyanosis. Cyanosis indicate poor oxygenation of the blood, and then grunting, that also indicates difficulty in breathing. So on the basis of all these findings, we can classify the pneumonia, and this is known as IMCI classification of pneumonia. For classification of pneumonia, we must know the danger signs. If the age of the child is 2 months to 5 years, the danger signs are fever, malnutrition, general danger signs like the child is not feeding well and is drowsy and is having convulsions. Then the danger signs related with the respiratory system like wheezing, cyanosis, and stridor. Age of the child is less than 2 months, we classify pneumonia into 3 categories: no pneumonia, severe pneumonia, and very severe disease. If the child is having a normal respiratory rate and there are no subcostal recessions, this is taken as no pneumonia or simple cough. These children do not need any aggressive treatment with antibiotics or hospitalization. They can be managed at home by simple home remedies like honey water, tea, and severe pneumonia is when the child is having fast breathing. The rate is more than the upper limit which has been already mentioned, plus there may be subcostal recession. So there is no category like pneumonia in a child who is less than 2 months, meaning by that their symptoms should be given some serious consideration, and it should always be taken as severe pneumonia and the child must be hospitalized. We label a child having a very severe disease when the danger signs which have been already mentioned are present, like general danger signs. The child is not feeding well, the child is vomiting, the child is drowsy, or mother says that the child has had a episode of convulsions. And then certain danger signs related with the respiratory system like wheezing, stridor, and cyanosis. When the child is 2 months to 5 years of age, we classify the pneumonia into 4 categories like no pneumonia, pneumonia, severe pneumonia, and very severe disease. No pneumonia when the child has normal respiratory rate and there are no subcostal recessions, then this will be labeled as simple cough and or it is a upper airway disease. Then we have pneumonia. In this category, the child has fast breathing. The rate of respiration is above the limits which have been mentioned. In severe pneumonia, the child has subcostal or intercostal recessions indicating increased work of breathing and decreased lung compliance. Similarly, in very severe disease, the child will have not only fast breathing, subcostal recessions, but also danger signs. Severe pneumonia and very severe disease should be admitted in the hospital. Generally speaking, the symptoms of pneumonia are the child will be having anorexia, malaise. There may be fever with chills and rigors, myalgias, arthralgia, pleurisy, chest pain, and there may be hemoptysis in older children. The child will be very much dyspneic and there will be preceding history of upper respiratory tract infections. The child may have abdominal pain, particularly in the upper quadrant when the child is having lower lobe consolidation, and this may be confused with the diagnosis of acute abdomen. There may be parenteral diarrhea. So these are the basic symptoms of pneumonia. On examination, the child will be having increased respiratory rate. Then there will be intercostal or subcostal indrawing, and if the child is having lobar pneumonia in which a large portion of the lung has undergone consolidation, then on examination we will find that on the side of lobar pneumonia there will be decreased chest movements, and on palpation the trachea and the apex beat will be normally placed. Percussion node will be dull on that area, and on auscultation we will hear bronchial breathing and there will be increased vocal resonance over the area of consolidation. Remember one thing, that in a normal child we can hear bronchial breathing over the trachea, and when there is consolidation of the lung, this bronchial breathing is directly conducted to the chest wall, and so we will hear the bronchial breathing on the chest wall. At the same time, the vocal resonance will be increased. We ask the child to say 1, 2, 3, and we listen the chest. Over the area of consolidation, the sounds will be increased. Remember one thing, that in case of consolidation, there will be no shifting of the mediastinum, so the trachea and the apex will be normally placed, and then there might be crepitations. While in case of bronchopneumonia, in addition to the increased respiratory rate, in addition to the subcostal and intercostal recessions, we can hear crepitations. These are the crackling sounds which are mainly heard towards the end of inspiration, and they indicate the opening up of the collapsed alveoli. So the trachea and apex beat will be normally placed in a case of lobar pneumonia. Now, coming to the diagnostic workup of pneumonia, the X-ray test is the most important investigation. In bacterial pneumonia, the area which is affected will be visible as a dense white patch. As the X-rays or X-ray beam does not pass through the consolidation compared with the nearby healthy lung tissue that appears black. In viral pneumonias, we will find scattered white sticky shadows. And in case of bronchopneumonia, we will find small areas of consolidation. So there will be patchy consolidation of the lungs that will be visible on the X-rays as small white patches over the different lung zones. Now look at this X-ray. You can see that this area has undergone consolidation. This is adjacent to the right border of the heart, and this area indicates middle of consolidation. So at this area you may find bronchial breathing and crepitation with vocal resonance increased. Remember one thing, that in this X-ray you can see that the trachea is central and the heart is not shifted. So there is no mediastinal shift in cases of consolidation. Now if you look at these X-rays, this X-ray again indicate some areas of consolidation favoring bronchopneumonia. In this X-ray, the right lower zone indicate a white opacity, which is an area of consolidation adjacent to the right border of the heart, indicating involvement of the middle lobe. At the same time, you can see that the angle has also been obliterated, particularly the costophrenic angle and cardiophrenic angle, indicating that there may be some parapneumonic effusion. Now, this X-ray again shows an area of consolidation. Now, if you will examine this patient, definitely there will be decreased chest movement on this side. Trachea might be central, apex beat may be normally placed, but on this area on auscultation you will find bronchial breathing and increased vocal resonance. The other investigations which can be ordered are complete blood count. In case of bacterial pneumonias, you will find a high TLC count, and the neutrophils will be increased. Blood culture and sensitivity in very sick children, you may be able to culture organisms from the blood samples, and at the same time the sensitivity of the organisms to the drugs will help us in modify the treatment. Then we can have sputum, tracheal or gastric aspirate for culture and sensitivity. Arterial blood gases are very important, especially in critically sick patients. And in addition to the monitoring of the vital sign, the saturation of oxygen must be monitored in order to regulate the flow of oxygen to maintain the saturation in the normal range. The treatment of pneumonia can be categorized into two groups. One is the sportive treatment and one is the specific treatment. The sportive treatment is, of course, the bed rest, good diet, give palatable, soft diet to the children, having good taste. Then oxygen inhalation to maintain the saturation of oxygen above 90%. Then give antibiotics, and if the fever is very high, we can do sponging with the lukewarm water, and we must ensure adequate fluid intake. If the intake of the child is not adequate, then we can give IV fluids to these children. Chest physiotherapy is important to get rid of the secretions which accumulate in the respiratory passages. The specific treatment to some extent depends upon the age of the child, because at different ages different organisms cause pneumonia. So antibiotics are given according to the most likely causative organism at that particular age. For example, in newborn, group B streptococcus and E. coli are the commonest organisms. So we can give amikacin, gentamicin or ampicillin. In older children, the pneumococcus is the commonest organism, particularly the children having lobar pneumonia. So in that cases, the treatment of choice is benzyl penicillin. However, first generation cephalosporin can also be used. The cloxacin and vancomycin and linezolid are the drugs which are particularly effective in cases where we suspect staphylococcal pneumonia or where we have isolated Staphylococcus aureus from the blood cultures or from the sputum or tracheal aspirates. Clarithromycin is the drug of choice in case of atypical infections like chlamydia or mycoplasma, and if there is any evidence of tuberculosis, then obviously we have to go for anti-tuberculous drugs. Now, this is another frequently asked question in the examination, that what are the complications of pneumonia? So the important complications of pneumonia are empyema, that is the accumulation of pus in the pleural space. And whenever there is empyema documented clinically and on X-ray or on ultrasound or CT chest, it will require drainage by putting in a tube. Daily aspiration of pus is not recommended, and this will be accompanied by a long-term treatment with antibiotics, and this treatment may be required for 4 to 6 weeks. Then the patient can develop lung abscess, and lung abscess will of course require drainage. It may be ultrasound guided or CT guided drainage of the lung abscess. Then the child may develop pneumothorax. Pneumothorax is the accumulation of air in the pleural space. When this air accumulates, then it can cause mediastinal shift towards the opposite side and compromise venous return and cardiac output. So this is a life-threatening condition, and the pneumothorax require immediate intervention. We can put in a needle with underwater seal in the second intercostal space. Similarly, the child can develop pleural effusion, which will require drainage by putting in a chest tube. However, in a patient who is having tuberculosis and there is accumulation of fluid in the pleural space, or in the pleural effusion, tuberculous pleural effusion, this pleural effusion may not require tube drainage. In addition to the anti-tuberculosis drugs, the patient will be given steroids, and this will and the pleural effusion will ultimately will automatically reabsorb. Patient can develop respiratory failure, and this will be indicated by high carbon dioxide and low oxygen in the blood gas picture, and these patients will require ventilator support. Sometimes the patient can have metastatic septic lesions like arthritis or osteomyelitis, or infection at other sides of body, particularly the skin. There may be abscess formation, and all these require treatment accordingly. Pneumonia is preventable disease in pediatrics. Pneumonia caused by Haemophilus influenzae, pneumococcus, or pneumonia caused by Mycobacterium tuberculosis, or pneumonia caused by measles virus, they can be prevented if we timely vaccinate the children. The vaccines for the Haemophilus influenzae, the vaccine for the pneumococcus, the vaccine for the tuberculosis, a vaccine for the prevention of measles, they are available, and these are easily available, and when given to the children, they can prevent the development of disease by these organisms. Remember one thing, that Haemophilus influenzae and pneumococcus, tuberculosis, measles, they do affect the lungs, but at the same time they can affect the other systems as well. Like, they can cause meningitis, they can cause meningoencephalitis, they can cause infection of the bones and joints. So if we give a vaccine to the children against these organisms, so they are protected against a wide variety of illnesses. So thank you very much for patient listening, and I pray that may Allah protect our children from pneumonia. Thank you very much.